this out so that we can continue. Stay tuned for registration info for our next Donatelli and BJ Stasio will be joining us. We'll be sending out our announcements for our future. Also go to our erie.gov/mental health website for announcements and registration information as well. All of the presentations and recordings for our past offerings are posted on the site, so we'd encourage you to check those out. The recording and slides from today's will be posted there within the next few days. We are still working on our entire calendar for 2024, and we'd love to have our community. So if you are interested in doing a 1-hour presentation, please indicate that on your evaluation, or you can email Amy Rockwood at amy.rockwood@erie.gov. Our training today is being recorded. Everyone is muted. If you have questions, please put them in the chat box. I'll be monitoring during the presentation, and Amy will be answering questions as we go. Thank you all for joining us today, and I'd like to introduce Amy P.
Thank you. Kathleen, I'm sorry, in the chat, it says that you're cutting out. So I just wanted, expectful here. Okay, perfect. If I cut out, please let Kathleen know in the chat, and then we'll have to figure something out. But welcome, everyone. I appreciate you all deciding to spend some time with us today to talk about multiple diagnoses with folks with developmental disabilities. This is not the most formal of presentations. It's more a conversation, some things to maybe think about when we are supporting people with developmental disabilities that have more than one type of diagnosis, which we understand is prevalent. So I want to preface this content by saying we developed it to help our care coordinators really kind of come to some understanding around the concept of overshadowing and foreshadowing when they are helping someone with developmental disabilities in the medical space. So take what you can from it. I will try to tailor my comments accordingly, and not knowing who is in fact on the webinar. So I just wanted to let you all know that. So I tried to tailor it, but I might have missed some terms and all of that kind of stuff. So, all right, multiple diagnosis. Let's see. How can I knew I was gonna have stress. Okay. I am from Person-Centered Services, Care Coordination Organization, and this is our mission, vision, and core values, and we include it in every presentation that we do. So I'm not gonna read these to you, but I just wanna explain a little bit about who we are and what we do. So we are a health home care coordination organization that serves almost 18,000 people in the 18 westernmost counties here in Western New York. And we are a health home specific to people that have been diagnosed with developmental disabilities and are eligible for waiver services through the Office of People with Developmental Disabilities system. There are 7 CCOs throughout the state, 2 in our particular region here in Western New York, us and Prime Care, and because people need a choice. And so what we are is a niche health home, basically, that much like your traditional health homes, only we serve folks with developmental disabilities. So I just wanted to clarify that. So here's the agenda, what we're going to cover today. Just like some very, very basics about what we're talking about. I wanted to talk about some prevalence of multiple diagnoses in people with intellectual and developmental disabilities. I wanted to talk about some real world information that we have as a result of our huge population that we serve at Person-Centered Services. So we're able to like glean some, real live information from that. Have a discussion about the chicken or the egg, which is always fun. And then my last couple of slides are some basic tips and resources. So basic terms, which many of you all know from the treatment world, right? What is a diagnosis? What are signs? What are symptoms? What's a behavior? And what are the types of diagnoses that we see in people in general, and specifically people with developmental disabilities? So I only talk about this slide because I think it's important to at least mention the fact that sometimes folks with developmental disabilities get pigeonholed into their behavior being merely behavioral and not a function of a diagnosis. And we could probably debate this for hours and days. But really, behavior, right, is a functional occurrence or act, and it's no different than a sign or a symptom of a mental or behavioral health issue. So I feel that sometimes we use that term, it's just behavioral, to diminish like what is happening with a person and to really kind of get at the core understanding of the function of that behavior. And is it a symptom? Is there something else going on? Is it indicative of some type of diagnoses? And so that's kind of the point of this slide, is to just to bring that out. Obviously, I have the types of diagnoses on here. So there's medical, clinical, mental health, substance use, all types. And then we all know that depending on what type of diagnoses and area of expertise, it determines who can make that diagnosis. So oftentimes in care coordination, we are taking information from family members, from school districts, from everywhere, right, to try to build support for this person and to try to figure out the best way to kind of help them and improve their quality of life. And so it's important that we get a diagnosis from an appropriately credentialed person that has the expertise to make that diagnosis, and that we try to have these diagnoses be as accurate as possible. The care coordinators that I work with, do lots of assessments and information gathering. And so they are trying to get information from all sorts of sources around diagnoses. And sometimes, they're not accurate, or they're very, very old, or, they're no longer applicable. So I only talk about this because I feel like it is very, very vital that people have an appropriate diagnostic picture, because diagnosis helps drive treatment, right? And helps us improve somebody's quality of life. And so if we don't have an accurate diagnostic picture, it's hard to, follow the thread from there and get the person exactly what they need, and, that it's going to be helpful. Ooh. Okay, so these are just some basic, I was going to call them like myths or urban legends or whatever you want to call it, but they are statements, okay, or beliefs about people with developmental disabilities and diagnoses. So before I go on, though, I want to talk about the term multiple diagnoses and why I'm not saying co-occurring or dual diagnosis, which back in the day that used to kind of mean some things. It depends on what discipline you're from. If you're from a drug and alcohol background and someone says co-occurring, to me, I've worked in the drug and alcohol field for a long time. That to me meant mental health and drug and alcohol, or a substance use issue. When someone said dual diagnosis to me, then I felt, I thought that meant mental health and developmental disabilities. But it depends. It's colloquial. It depends on where you are in the country. It depends on your expertise. So the term du jour, so to speak, these days is multiple diagnoses. And I feel like it's super accurate and specific, right? You have more than one diagnosis, depending on, what you got going on. The other thing is a comorbidity, seems to be a highly clinical term, obviously, that doctors use and all that kind of stuff. But essentially, right, you've got more than one thing happening. You have more than one diagnosis. So I just wanted to make that clear before we move on to the next slide. So some statements. I'm not going to read them all, but I do just kind of want to talk about it. People with developmental disabilities often exhibit aggression or self-injurious behavior. Again, this goes back to that's behavioral. What is that about? Like trying to find the meaning, right? Doing a behavioral analysis, trying to figure out what the purpose of that behavior is. Is it a symptom of something else going on? Another myth or belief about folks with DD that some people have is that they can't experience human emotions like you and me. And so when we talk about depression, anxiety, things like that, or personality disorders, sometimes people with developmental disabilities are kind of disenfranchised from that because people believe that they don't experience life or human emotions like people without developmental disabilities. And that is absolutely not true. Um, People with developmental disabilities can't feel oppressed by their dependence on others. They absolutely can. And so when we think about depression, anxiety, lack of independence, those kinds of things, and though the impact that those things have on somebody's mental health, folks with DD are definitely susceptible to all that stuff. This is a huge one, that people with DD can't benefit from mental health, behavioral health, or substance use treatment, and that medication is the only option. We have so many options and treatments and programs available really in for people that have mental health issues and physical issues. But oftentimes folks with DD are excluded either formally or informally. So I understand that formally, never will you see in a service description, I would hope that I would never see that somebody with developmental disabilities is excluded from a program or therapy or treatment based on their developmental disability. But what often happens is we get that conversation around, is this person going to fit in with the milieu, especially if it's like a group setting? Is this person going to be able to do the work that needs to be done, internally for to benefit from this treatment modality? Substance use, same thing. Is this person going to fit into, a rehab thing? All that kind of stuff. And the answer is, it depends on the person, right? It's just like every other person, every other treatment. If it has to be assessed individually and it has to be talked about with the person and the family and to figure out, is this person going to really benefit? And I think, but if you have takeaway from one thing from today, it's like, can we try? Can we at least like try and not just say absolutely not? Because the real truth is, in the OPWDD world, our services are about maintaining, about skill building, those kinds of things, and not really about treatment. And so some of these diagnoses need treatment, right? And so we need folks with developmental disabilities to have access to that treatment. People with DD are just attention seeking. That one we hear all the time, as do we hear from folks with just mental health diagnoses also. And then since they're just behavioral, which I talked about already, we can fix bad behavior by punishment and consequences. That is probably the most insidious one, because it really does simplify what's happening with a person, and really reduces it down to, positive, negative reinforcement, which is not how humans work mostly. Okay, so every time I go to, oh, sorry guys. Oh, here we go. Okay. I can't see. So this is the spiel I just gave about a better way to talk about dual diagnosis. So we're going to say multiple diagnosis. A person can be diagnosed, obviously, more than one thing at a time. And then they can obviously be diagnosed with both developmental disabilities, medical conditions, mental health conditions, substance use disorders, right? We have folks that we serve here at Person-Centered Services that have many, many diagnoses. And then we have some people that only have their developmental disability. So obviously it's the whole spectrum. What we see at Person-Centered Services. So I just wanted to talk about this for just a second. So we have a group of folks that use the emergency room and the hospital more than the average person. Okay. And so we have set some criteria internally here at Person-Centered Services that if if somebody goes to the ED once in 30 days, or they get admitted to the hospital once in 90 days, that is at a higher prevalence than the general population. And so we consider them kind of high risk and want to really get in there and figure out like what's going on with this person. So for 2023, we had 256 people that we support that met that criteria that I just described. So the reason I'm bringing this up is 14 out of those 256 only had one diagnosis. They only had the diagnosis of developmental disability. And then the majority, the other part of that group, obviously had more than one diagnosis. So I did some real quick down and dirty research before I hopped on here today. And the general guidance from the research is about 40 to 50% of folks with developmental disability have some other diagnosis. So it's half, right? It's a good half of the people that we support. The next point on this slide is for conversation. You know, what are some of the diagnoses that we see in the people that we support? Here at Person-Centered Services, we have lots of chronic medical conditions that our folks have been diagnosed with. So we have that, we have substance use things, and we also have serious mental health issues that people have been diagnosed with, and then, you know, coupled with their IDD diagnosis. So what do we know about this? We know that people with DD are likely to be diagnosed inaccurately and unnecessarily with some disorders. Because why? Because of the behavioral component that we just talked about. So we see a lot of oppositional defiant, we see impulse control disorders, we see some psychotic disorders. But at the end of the day, when you do a deep dive and you really kind of dig in and get this person a really good assessment, it might come back to something else. It's not necessarily one of these externalizing behavioral disorders. It might be something else that's going on with this person. And then the other thing is some of the more significant diagnoses get downplayed because the person has developmental disabilities. And so we have seen many, many times where a person with developmental disability who has experienced serious trauma does not get the attention that it deserves or needs because it is downplayed, because it goes back to those myths that I talked about from the other slide. You know, folks with DDD don't experience things like everyone else. So the fact that, you know, they didn't really understand what was happening in the moment means that they didn't experience the trauma like somebody that maybe would have that understanding. And that is absolutely not true. And those of you that are trauma therapists, I hope that you're hearing me, and I know that you agree with me that that is absolutely not true, right? Trauma lives in the body. There's all that physiological stuff that happens just like it does with people that don't have DD. So it's all of those things. And then the complexity of signs, symptoms, and behavior make it difficult to tease out. So here's the dealio with the chicken and the egg. So again, I said this content was for care coordinators, and this was, this becomes not an issue, but it can take a lot of attention when it really doesn't need to take the attention, because at the end of the day, chicken or egg really doesn't matter, right? It's about where this person is in this moment and how we can move them along and improve their quality of life by either treatment, supports, or whatever. And so what I always say to care coordinators is it can be an interesting discussion, and yes, you'll learn some things if this is the road we want to go down, but let's not spend our energy, okay, about the chicken or the egg. Let's spend our energy on getting the person moved along and supported and the treatment that they need. So I don't know if that's controversial, because some people really believe, and some treatment modalities really believe, we have to get to the heart of it before we can treat it, which is true, but I just don't want care coordinators and folks at health homes and all that kind of stuff spinning around this issue. And then always advocate for the ruling out of medical and physical complaints, right? So we know that some physical medical situations can mimic mental health issues. UTIs are a huge one. If somebody's sugar is or glucose is not controlled, or insulin, then they can appear psychotic, those kinds of things. And so it's always important to rule out the medical first. Because why? Because it's black and white and we can get it done, and then we can move on from there. And then we know that the person is getting the medical treatment that they need, or the medical issues have been addressed, and then we can move on to the other stuff. Kathleen, any questions or anything?
No, no questions yet. No questions.
Okay. And then the main thing about today is to think about this concept of overshadowing. So overshadowing is when signs and symptoms are attributed to the developmental disability or to a mental health disorder without due consideration of other possible causes. And I will say that this does happen with folks with serious mental health issues also, not just people with developmental disabilities. So they may experience overshadowing in different environments. So schools, medical facilities, OPWDD services, and then obviously non-OPWDD providers. So why does this happen? So lack of formal training. Although I will say, in preparing for today, I went in and did a little bit of research, and I see that there are lots of options for medical people to increase their understanding of developmental disabilities if they so seek them out. What I don't know is how many hours or formal education or training do medical people get about developmental disabilities in their specific training programs. I think it's getting better. I just don't think it's, where it needs to be yet. It's way better than it was, but I have so if anybody has that and they want to put it in the chat, I'd be curious. And then we have bias and stereotypes, right? So if somebody with a developmental disability it goes to the emergency room every other day, they get to know the staff there, and they're like, oh, it's John, and John's coming in, and he comes in every other day, and he says he has a headache, but nothing ever comes of it, and it doesn't seem like he has a lot of structured time, and so those things. Then those things, the next time he comes in with a headache, right, they're going to treat him like they did before. But this could be the time. This could be the time that there's really something serious going on. And so that's like a typical overshadowing situation. The tunnel vision, attributing everything to the developmental disability and not considering any other alternatives, is a huge thing with the overshadowing. Lack of available information, key, and then limited exposure to a specific group of people. So the treating person or the provider just might not have experience, right, dealing with folks with developmental disabilities. And so they see everything through the lens of a person without developmental disabilities, and try to fit the person with DD into that lens. And sometimes it's just not a good fit, and they miss things. How does it impact the people that we support? So obviously the needs and the experiences are not taken seriously. And then our huge issue is the inaccurate diagnoses and treatment. We've had people go to the emergency room in extreme pain and not be believed. Okay. And then the other thing is, right, if I'm in physical pain and I don't communicate verbally, what does that look like for me? How do I express that I'm in physical pain? So that's when folks with DD they either have to rely on their family members, their care team, to interpret for them, and to say to the treatment provider, dude, this guy's in pain, and this is why I know A, B, C, D, and E, which is another step, right? It takes more time, it takes more sensitivity. But it's key, because those are the things that need to be communicated in order for the person to get the help they need in a timely way. And I read notes all the time. Obviously, I'm in the Rio, I'm looking at treatment records all the time. And you can see a pattern sometimes of somebody going to get medical treatment because of pain and not being believed, or the extent of that pain, that physical pain, isn't able to be communicated clearly because the appropriate people weren't in the room. And then the person doesn't get the help they need and they continue to suffer. That's really awful, right? And none of us want to see that. And so contributes to prolonged suffering, and then the unnecessary strain, the back and forth. I gotta go, my family has to bring me to the ED again because my core issue didn't get addressed because of this overshadowing. And then the stigma and the mistreatment of people with developmental disabilities. We know from stats and records and all that kind of stuff, some folks with DD are over medicated. Okay, why? Because it helps manage their behavior. They are unable to maybe express specifically about side effects. Like, all of those things come into this. And so we see a group of folks, people with developmental disabilities, that may be over medicated, wrongly medicated, the treatments aren't accurate, they're not helpful, all of those kinds of things. Make sure. All right, so how do we reduce overshadowing? Boy, it's hard, right? Because it takes work on the care coordinator's part, or the treatment provider's part, and the person with the developmental disabilities. So we got to become aware and pay attention, right? Awareness is key. That's the first thing. And then we want to accept that people with DD experience the same mental and behavioral health concerns as those without it. That's full stop. It's same. A person is a person, right? Understand that people with DD can experience loneliness, low self-esteem, sadness, loss, rejection, disappointment, fear, trauma. So this goes back to, sorry about this. This goes back to kind of thinking that folks with DD don't experience the world like other people. And so some of these concepts, right? Low self-esteem, sadness, rejection, disappointment, those are like pretty complicated feelings. And so some people have some judgment around, there's no way a person with a developmental disability is able to understand these like high complex concepts or feelings. And at the end of the day, it doesn't matter if they understand it, right? They feel it. And so that's the issue. Advocate for accurate, thorough assessments. Okay, key. If a specialist is recommended, then a specialist should be seen. Okay, it's not about resources. It's about trying to find this accurate assessment, trying to get a thorough assessment, exam, therefore a diagnosis, therefore an appropriate treatment plan, right? Understand that signs and symptoms of clinically relevant concerns may appear differently. Okay, so lots of you are familiar with the DSM-5, and there is a companion book or text, whatever you want to call it, that's called the Diagnostic Manual for Intellectual Disability. So it's the DM-ID2. And basically it takes all the mental health diagnoses that are in the DSM-5 and kind of converts them or expands them to show and to describe how somebody with a developmental disability might exhibit and show signs and symptoms of that diagnosis. It's a really great resource. And so that's where it really gets into the behavioral versus the mental health and all that kind of stuff. And then understanding that all behavior is a sign and a symptom, and that serves a purpose and it communicates something. And just because it's not the way that you would communicate it, right? Or somebody without developmental disabilities would communicate it, doesn't mean that the communication is less valid. It's about learning that person and trying to figure out what they're trying to communicate. Okay. And then here's a key part that would probably impact all of us on this call. When you are supporting somebody with a developmental disability or helping them advocate for themselves, it's really about providing that neutral, detailed, accurate, unbiased information, right? Stick to the facts. This is going on. This is how long it's been going on. This is what it looks like. and then really kind of sticking to the facts, not hypothesizing about why or when or whatever, but like really sticking to it and being clear so that all the professionals and providers get the same information in the same way, and then we can do with it, what we need to do. Pay attention to the changes in the person's meds, environment, circumstances, behaviors, right? We all know some folks with DD are hypersensitive to change, right? Meaning any change in routine, change in care scene, change in anything, clothing, whatever, can kind of trigger them and really kind of put them in a downward spiral. So you've got to kind of think about all areas of a person's life when changes occur, and really kind of trying to figure out what's up. And then be conscientious of biases and myths, and remind others of their biases and myths while advocating for the person you support. So it is hard. It is hard to be with providers and kind of stick up for a person with developmental disabilities, or they stick up for themselves in saying, I need you to take my signs and symptoms seriously, right? I need you to consider them without my developmental disability so that I can get an accurate diagnosis, treatment plan, all that kind of stuff. Okay. So
Amy, just
yes, go ahead.
Comments that came in that I want to just mention before we move on.
Okay.
One that came in was, I'm glad you're raising awareness because we do not integrate our systems very well. Another comment that is, appreciate that you addressed it's behavioral statement. See the path, the treatment and care stop when that phrase is spoken.
Yeah.
Last comment was also in regards to, I think, also providers who will treat someone with IDD.
Okay, you cut out. I didn't hear the last one. I'm sorry.
Providers who will treat someone with IDD.
Oh, there aren't enough. Is that what?
Yeah, I think so.
Yeah, I mean, absolutely true. Absolutely true. Yeah, so we're constantly, because the CCOs are kind of in a special situation and we have access to, all this data and all this assessment stuff, we really are trying to work with OPWDD to like identify gaps and really try to figure out, what's the best way moving forward. And although folks at the state, in the state systems and all the other O agencies, we do really try to work together. Unfortunately, the funding and the boundaries that are put up to cross each system is a problem for sure, for sure. But I'm always like, we gotta have, I moved here from Pennsylvania 5 years ago, and we had a dual diagnosis treatment team, which was fashioned after an assertive community treatment team. And it was for folks with developmental disabilities. And it was such a good model, but very expensive, all that kind of stuff. And so I'm always like, why don't we have that here in New York? I don't understand. So, I mean, obviously lots of work to be done, but yeah. So some key takeaways, obviously overshadowing can impact accurate diagnoses. That's really the key of today. And then accurate diagnosing takes time, right? It takes time, it takes assessment, it takes time and effort on everyone's part, including the person with developmental disabilities, because they have an active part to play too. They still have, they got to go, they got to participate, they have to do all of those things. And that can get super frustrating for people. We know we want to go to the emergency room. I want to go to urgent care. I want you to swab my throat because my throat hurts, and I want you to give me an antibiotic so I can leave. I don't want to have to go to 18 assessments and an ENT and all that kind of stuff. But sometimes that is what is required in order to get an accurate diagnosis. And then we always want to rule out medical, all that kind of stuff. Don't get caught up in the chicken or the egg thought process. And then people with developmental disabilities should not be excluded from traditional talk therapy, group therapy, substance use treatment, obviously case by case. But again, person-centered, let's talk with the person, let's talk with the program, let's talk with the provider and see, is there some way we can, try and make this work? I've seen it go both ways. You know, I've seen it work great and I've seen it not work great. And it's like, it doesn't work great for people without developmental disabilities too. So that kind of thing. And then the strategies. Okay, so I've been saying that the person with the developmental disability has a part to play also. And the thing is, we all know from our own personal experience or family members or whatever, when there are multiple diagnoses involved, it can get to be a lot. And so it's really important that we have materials and reference things that a person with a developmental disability can refer to and look at, or either a storyboard or something that helps explain what is going on and that they have multiple diagnoses. Because the other key thing is like how they interact and all that stuff. So you've got to come at it from where they're at and in a manner in which they can understand things, which again takes time, takes effort, and these things aren't always readily available. Here at Person-Centered Services, we have a clinical team, and sometimes they have to create things, right, in order to help the person understand it. Because the other thing is we want the person to be able to make their own choices and to be able to have all the information and make the best choice that they can possibly make for themselves. Then this is a life plan. This is one of the things I should have taken out, but I did not. So as a care coordination organization, a person gets a service plan, and that's called a life plan here at Person-Centered Services. And in that life plan are all the person's whole life, like their whole diagnostic picture, their whole treatment picture, all the providers are listed. And so if you're helping somebody, as somebody on this webinar with DD, and they have a care coordinator, you should be listed on the life plan because you are a key to their treatment regimen, right? Their treatment plan. And then many psychiatric conditions are cyclical, right? So signs, symptoms, coping strategies, length of episodes. So this goes back to that being factual and accurate in what you are describing when you are supporting somebody with DD. Like these are the things you kind of need to pay attention to, right? So that you can report out when the person is getting assessed, or the person themselves can keep track of these things and then report out so that we can get an accurate assessment. And don't downplay the impact of trauma, right? Not only does it impact your mental health, it impacts your physical health for sure. And I would say maybe for folks with developmental disabilities that you know, maybe don't have the vocabulary or whatever to process it verbally, that it probably impacts their health even more so because they have no way of like, you know, processing it and kind of getting it where it needs to go. And then this is some resources. So this webinar that I just did was based on a really lengthy webinar that was presented in 2021 from OPWDD. You can Google it. It's so good. It has all of the stuff about overshadowing, has many more resources. And then we have NAMI on there. I also am excited that BJ and Max are going to be coming next month to talk about advocacy. They are part of a group called SANIs, which are the Self Advocates of New York State. They have some really good videos on their website that show providers how to interact with folks with developmental disabilities. And it's so simple as like, don't talk to their caregiver, talk to them. But there's like a role play video where they show a doctor and a doctor's appointment and all this kind of stuff. So it's really, really good. And they will talk about that next month. But if you wanted to Google it, that would be a good place to start. And then that is all I have. Sorry, I knew I would get done early.
That's okay. We do have some questions that came in. I'll read it, but obviously knowing that my sound might not complete it is also in the chat. How do you propose we get SPOA and OPWDD to utilize a person-centered planning process? One says it's mental health, go to SPOA. Then SPOA says it's DD, so go to OPWDD. If there are multiple diagnoses, how do you not get caught up in the chain because each agency is making determinations about primary diagnosis?
Yeah, that is so true. It is so true. So from a diagnostician treatment provider the chicken and egg probably is a little bit more important than from a care coordination perspective. So let me just preface that. But so we've had cases or situations where we've worked with people that are obviously supported by OPWDD, but then what happens is that waiver piece, right? That funding piece. So it's like, do we discontinue their OPWDD waiver so that they can get mental health services? But we have been able to go through, I think it was Niagara County, SPOA, and get a person like actually enrolled in the ACT team while they maintained their care coordination through us. We had to get like special permission. Like, that's the thing. It can be done. It's just, it takes way too much time and effort. And so it doesn't happen on the reg, but like it can be done. And I will say at the state level, the commissioners are saying, we are meeting regularly. We are talking about the cross system stuff. So, everybody stay tuned. I know in other states, they've done like memorandum of understanding across the systems to say like wherever that person enters, whatever system they enter into is ultimately the payer of the services, but the other systems will reimburse. Like there's all kinds of different models. I think it takes time though to get it all squared away. I don't know if I answered the question. I ranted, but.
Thanks, Amy. Another comment that came in is having information in different ways for consumption, allowing them to be autonomous with decision making.
Yes, very much. Because that's another big misconception about people with developmental disabilities, is that they don't have the capacity or the wherewithal to make their own decisions. And the truth is, if you are over 18 in the United States of America, you have capacity to make your own decisions until proven otherwise. And that is exactly true for folks with developmental disabilities. So unless someone has a legal guardian, okay, they are their own decision maker for sure.
All right, I think that's all the questions that I saw come in. So just a few things on our end to wrap up with. Obviously, thank you, Amy. That was a great presentation.
Thank you all very much
for coordinating. Amy has the link to our evaluation in the chat box, so we just ask that you take to fill that out for us. The recording and the slides of today's website in the next couple days. So if you'd like this great information, just reference back to our website and that will all be there. Again, stay tuned for info on our April session, and that will, like Amy said, will be with BJ Stasio and Max Donatelli. So stay tuned either on our website or you'll receive that as well.